I'm a believer. I want you to drink the Echo Kool-Aid now. I have no disclosures for this talk. I'm mad at Marwan because he gave me this talk last minute. I love hemodynamics, but I'm going to mix the echo part to it because I think there's two parts to this puzzle, not only the PA catheter part. So we're going to briefly go through introduction, review data of echo parameters, and then finally we'll conclude. And I hope Dr. Mann doesn't say that, again, we don't know anything about echo. So I think when we talk about shock, I think from the echo perspective, three things we got to look into. We have a temporary circulatory support device. We ask ourselves, is this LV-RV recovered? Is the LV-RV not recovered? Is the LV-RV not going to recover? So your treatment is going to be based on that. So either you recover both the ventricles and you're going to remove the device, or your RV and LV are recovering, but you need more time, or the RV is better, but the LV is not better, so you're thinking in terms of a left ventricular assist device. Both LV and RV are not going to recover, then we're thinking about total artificial heart or palliative care or transplant. So why we use echocardiography? So most of the data, this is all, there is no randomized control data, so whatever I say is gospel truth. So I'm going to tell you what we do in our institution. So I got to go with the background. So the TEE came about mainly at the time of cardiopulmonary bypass. Pretty much all the cardiovascular anesthesiologists put in a probe. So I've had an opportunity to go to the operating room many times. So what I was learning through that process is when the heart comes off cardiopulmonary bypass, what exactly is the LV-RV function? And it gives some tool for the surgical team as to whether they need some form of support, a balloon pump or some kind of pharmacological therapy after they come off, or do they need some more support like ECMO? So that's the background in which we started using echo as a parameter for weaning MCS. So there's not much data specifically. All this is what we call protocol-driven per institution. So routine echoes assess hemodynamics at one point in time, so you got to know that very clearly. We're not doing serial echoes, so things may change in 4 hours, 6 hours in time. Advantages of TTE, it's easily available. You have text around the clock. Unfortunately, the windows might not be the best, so you may not get good information. TE, on the contrary, clearly you're able to visualize the structures better. Again, limited availability and not routinely available for continuous evaluation. So shades of gray is going to be bad. Black and white is easy. So larger LV cavity, altered papillary muscle, verse MR, no-brainer. That ventricle is going to take some time to recover or may not recover. If the LV-EF is more than 28%, some of the studies have shown the outcomes are better. And I beg to say, Dr. Mann, I'm saying this LV is not recovered. I'm talking about LV recovery from temporary support. As you had eloquently said, recovered LV doesn't mean normal LV. So the EF is one of the numbers which we use. The second, we look at the mitral regurg. Now we look into more sexy parameters in echo. Unfortunately, there's no standardization for this, so it goes from lab to lab. So in cardiogenic shock, reduced myocardial velocities, higher filling pressures, we can get those assessments through echo. How do we do that? We look at the mitral annular systolic velocity, or the S prime. So anything more than 7.5 centimeters per second predicts a good EF. There's around about 79% sensitivity and 88% specificity. This is on multiple trials, short trials done in different centers. Lower the velocity, poor the prognosis. Then there's also a talk about the mitral annular early diastolic velocity, which is the E prime, which is a marker for the preload. So if you have a higher wedge pressure, you're going to have the EE prime, which is elevated, which again portends a poor prognosis, leads to increased stiffness, and everybody knows if there is stiff heart, that ventricle is not going to recover. So Ecmo Weaning, I think this is a very controversial topic. This is something we need to talk about in other shock symposiums, because I don't think there's any protocol per se given by the scientific committee. It's individualized per institution. But I think what our center does is this. We look at the improved LV function and aortic valve opening. So if the aortic valve tissue Doppler velocity index is greater than 10, if the mitral annular systolic velocity is greater than 6, it's potent, good prognosis based on smaller studies, so we look into that. I think I like the dynamic LV volume assessment more than anything else. The problem with the PA catheter is it only gives you a pressure. It doesn't give me an exact volume. I think echo is going to be fantastic in giving you a volume assessment. So if I have an LV which is shrunken and the pressure is higher on the PA catheter, that's a different phenotype compared to an LV which is distended and a wedge pressure which is distended. So giving that in mind, if my surgical team is coming and asking me, can I wean this ECMO off? So everybody, there's no brainer. If I turn the ECMO flows down to less than 2, the MAPS plummets, the heart rate goes up, the SpO2 goes down, we know that we're not going to remove that patient off of the ECMO. On the contrary, if the EF is improved to more than 40% and the aortic valve is opening well, the pulse pressure is more than 20, there's not going to be any brainer on that. The gray areas are these ones where your pulsatility is not that much, and at the same time, the EF is not that much. Then in these cases, I think what we should do is we should try to give some volume challenge. What happens to the left ventricular distension? What happens to the right ventricular distension? If it distends, it's a bad sign. The second thing is we got to give inotropic challenge and see the contractile reserve. If it's there, that's a good way to say that probably the person can come off temporary circulatory support. I'm not going to talk about the strains because, again, it goes from one echo lab to another, but generally LV strain increase of more than 20% is portends a good prognosis. And a progressive antegrade flow in the descending aorta, again, tells you that the stroke volume is good. Impella, very limited data. Basically, we look at the LVOT VTI serially and see if it improves. If it improves, that means the LV function is improving, so you can come off. Future directions, I think this is very exciting, which is basically a temporary TE probe. We can drop it down. It's basically 5 millimeters. You keep it for 72 hours. We can pretty much serially get the LV function, LV volumes, and septal shift. It gives us an idea how the LV looks like, how the RV looks like, what the volume looks like. It gives additional data on top of the hemodynamics to help people wean off the TCS. So currently, several limitations, TTE versus TE, continuous echo monitoring, specific parameters to assess, all those things are still vague. Echo provides additive data and helps in the decision to wean MCS along with the PA catheter.
So questions. Among the parameters you listed, if they're going in different directions, which one would you hang your hat on the most? I mean, oftentimes, if everything is getting better, it's a no-brainer. Oftentimes, we deal with data that are going in different directions. So among the parameters you mentioned, which are the ones that you take home as being the most reliable or highest specificity and sensitivity?
So 2 things, both the chambers act differently. If it's the right ventricle, I'm worried about the interventricular septum. If it's shifted towards the left, the tricuspid annulus is bigger, TR gets worse, that ventricle is not going to recover. On the left side, similarly, if the LV is distended, that ventricle is not going to do well. So those are the 2 surrogate markers of the echo, which I think is really important. The second is pathophysiology of MR. If you're having functional MR versus the P3, A3 segment MR, those MRs don't do well. So I would use those 2 as surrogate markers for recovery.
Comments from the panel?
Yes, so at Memorial Hermann, do you have the TE that can stay down for 2 or 3 days?
No, we are in the process. It's called HTEE, hemodynamic TEE. There is some data which is coming through from several other centers, but we are really interested in. Our trauma team wants to do that because they have a tough time to get surface echocardiograms, so they're really wanting, especially chest trauma patients, when they have cardiac contusion, they want to see them, so we are interested in co-partnering with them.
Having used it for a fair amount of time, the problem is that it's if you're used to regular TE, you'll be sorely disappointed. It's TE light. It can be interesting, but we've had experience.
Is it the quality of the images, or you just don't have as many GIGOS functional parameters that you can measure?
The quality of the images, and the other thing is that it takes time. It's like shaking an old Polaroid picture. You literally have to sit and watch the image develop. So it's very, very good for the RV. It's excellent for tamponade. Color is borderline, possible but questionable, and not as much because you can rotate it. all you like, but I've been somewhat underwhelmed. It's nice, but it's not. Maybe generation 2 or 3.0 would be better.
So in my mind, there are a couple of things. The PA catheter, if there is V waves, I'm not very sure whether the V wave is because of LV or is it because of mitral valve. The same way, if there is a Y descent in my CVP tracing, that ventricle on the right side is stiff. So the CVP of a stiff ventricle versus CVP of a dilated ventricle completely different, because then my filling pressures for filling the left side is going to be different when the RV is distended versus RV which is non-compliant. So I think there's definitely a role for echo to assess volumetric analysis and also to assess the degree of MR. I think we get burnt a lot because if you don't assess the MR correctly, that ventricle is not going to recover. The single most important thing which we do on temporary circulatory support devices is you're decreasing the MR. That's what is the main theme here. So,
Sriram, up here, I want to emphasize and maybe ask your thoughts on, I almost feel when you're weaning temporary MCS in the setting of, say, somebody needing a 5.0 impellant, I think there's a distinction of weaning it in the cath lab versus our advanced heart failure. We've had a lot of struggles in assessing it by just PA catheters, and I think I almost feel like it should be a mandate to use imaging on top of echoes for the volumes you're talking about, MR that you don't assess. We have a cohort of 6-7 patients where we have weaning protocol at different P levels, but I think it's important to acknowledge not to take away an MCS just by a false hemodynamics. To me, it's almost like just looking at a VAD and saying LVF looks okay and take a durable VAD out. I think all of us should standardize some kind of a assessment, especially MR becomes crucial because we've had a few, everything looks good, you take the 5.0 out and then they crash and you have to escalate back.
I think most of the information in our personal experiences through RAM study, we have always arguments because we have junior faculty members who mandatorily do right heart caths on all L valves. We learned a lot through echo ramp and hemodynamic ramps. And I think what people fail to understand is the septal shift. It's very important. So if you're using a temporary circulatory support device like Impala and you're trying to unload and you're trying to shift that septum to one side, it makes a huge difference to the right ventricle. So we are not looking at a right ventricle, we are iatrogenically making the right ventricle also worse. So I think we got to use both the parameters, both echo as well as right heart cath.
I have used both at the same time, right heart cath and echo in the cath lab. And I think one premise is what you see in the cath lab not necessarily is going to see what you're going to see when the patient comes back 2 months later.
Yes.
And you have wonderful hemodynamics, and you made the mistake of increase the ramp, the speed, and the next month the patient comes and feels miserable. So I think that is always going to be a problem when you're trying to do these numbers and you try to win off something, because that not necessarily is going to mean what is going to be happening with that patient later on.
Yeah, I think that's completely right. It's basically, the loading conditions in the cath lab is very stable. Whereas when you walk around, your afterload changes, your preload changes, obviously the way the chambers are going to react is going to be completely different.
Very well. Thank you so much.
Thank you.